Welcome to this educational program. This module provides an overview of Botox treatments for bladder conditions. There are other modules available that describe other aspects of these various bladder conditions in more detail. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. Botulinum toxin A, available in North America under the trade name Botox, has recently been applied for use in treating a variety of different bladder and pelvic health conditions, including overactive bladder and urinary urge incontinence, spastic urinary sphincter, pelvic pain, painful bladder syndrome, and lower urinary tract symptoms from prostatic obstruction, also referred to as BPH. This article will review this exciting new therapy, including when and how it is used to treat urinary incontinence. Before beginning this review, the following points must be made and taken into consideration. The use of Botox in treating bladder conditions is presently considered off-label. Botox has been given approval by the FDA in the United States and by Health Canada for use in treating a number of medical conditions. However, at the present time, these bladder and pelvic conditions are not part of this list, so its use in this setting is not as yet approved by these regulatory bodies. This treatment is therefore presently limited to a small number of specialists with an interest in these conditions, and it is only offered to patients with specific diagnoses, and only after other approved therapies have been tried. In some situations, Botox treatment may be limited to clinical research trials only. As noted, Botox is a purified form of botulinum toxin type A. There are 7 botulinum toxin serotypes, A, B, C, D, E, F, and G. Only type A and type B are in clinical use. All of these serotypes block the transmission of nerve cells and cause muscle relaxation. They are all produced by the bacterium Clostridium botulinum, whose spores are naturally occurring in soil and water. These spores can contaminate food and under certain conditions grow into a bacterium. Bacterium releases the neurotoxin that can cause a severe food poisoning called botulism if eaten. No cases of botulism have been attributed to Botox or to other licensed botulinum toxins. Through history, many important discoveries and advances in medicine have been made by observing nature and adapting naturally occurring compounds, plants, herbs, and even toxins to produce medicines. The development of Botox has been one of these remarkable and ingenious stories. Botulism was first observed during the Napoleonic Wars, when the Duke of Württemberg in Stuttgart recorded a growing number of deaths due to food intoxication. Smoked sausages seemed to be the cause of the problem, and the condition was given the name sausage poisoning. The potential use of Botox for medical purposes was subsequently realized by Justinius Kerner, a poet and medical officer who first suspected the condition might be caused by a biological poison. He published his first report on botulism in 1817. The bacterium Clostridium botulinum, from which botulinum toxin type A was eventually purified, was first identified as the cause of botulism in 1895 in Belgium by Professor Emile Pierre van Ermengem. However, it was not until the 1920s that a crude form of botulinum toxin type A was isolated. First attempts to purify the toxin were made by the team led by Dr. Hermann Sommer at the University of California, San Francisco. Botulinum toxin A was eventually purified in 1946 by Dr. Edward J. Shantz and his colleagues. Later, it was evaluated for clinical use for certain eye conditions called strabismus and blepharospasm in 1968 by Dr. A. Scott. Testing in humans began in the 1970s, and it received FDA approval for these uses later that decade. The first commercial product of botulinum neurotoxin A, Botox, developed by Allergan, received FDA approval in 1989. In the field of pelvic health, Botox was first used clinically for treating spastic urinary sphincter in 1987, and was then used in 1998 to treat prostatitis. Results of Botox use in treating bladder conditions were first reported in 1999 for incontinence caused by neurological disease, also called neurogenic bladder, and for non-neurological overactive bladder, as well as interstitial cystitis, in 2003. Allergan is currently conducting large clinical trials in various conditions as part of a drug registration process in the United States, Canada, and Europe. Botox acts to block the function of nerve cells where they meet muscle cells, a site called the Neuromuscular Junction. It prevents the release of chemicals called neurotransmitters, specifically acetylcholine, that normally are released from a nerve cell, travel across to a muscle cell, and signal it to contract. This results in prolonged relaxation of the muscle cell. This action of the toxin lasts for a limited amount of time, eventually wearing off as the nerve cells regain their ability to release these molecules. This drawing shows a normal neuromuscular junction, where a nerve cell meets a muscle cell. Vesicles, which are like tiny bubbles in the nerve cell, contain the signaling chemical or neurotransmitter called acetylcholine. Normally, this chemical is released from the tiny vesicles at the end of the nerve cell and travels across to the muscle cell to signal it to contract. The botulinum toxin A molecule, after injection, is able to attach to the surface of the end of the nerve cell. It then gets brought into the nerve cell into its own little vesicles in a process called endocytosis. The Botox molecule has two parts to it, called the light chain and the heavy chain, or simplified here as the first and second parts. The second part of the Botox compound is able to block the release of the neurotransmitter chemical acetylcholine. This removes the signal to the muscle so it remains in a relaxed state. Eventually, the nerve regains its function over a period of weeks or months. You may be a candidate for Botox treatment if you have an overactive bladder or a particular type of urinary incontinence called urge incontinence, and if you have tried other bladder relaxing medications for this called antimuscarinics without success. You may also be a candidate if you have bladder problems caused by certain neurological disease. Please note that Botox is not effective for the treatment of another common type of urinary leakage called stress incontinence. If this is the principal cause of your incontinence, your doctor will not likely discuss Botox treatments with you. As previously mentioned, Botox may also be considered in certain situations if you have problems with a spastic urinary sphincter muscle, prostate problems, or interstitial cystitis. This module is focused on Botox treatments for neurological or non-neurological incontinence or overactive bladder. Botox is able to work for all these pelvic conditions because normal urinary and pelvic function depends on the action of a number of different types of muscles, and spasm of these muscles contributes to many of these conditions. Much of the bladder is composed of a special muscle called the detrusor muscle. Spasm of this can lead to overactive bladder or urge incontinence. There is also important muscle tissue in the neck of the bladder, and spasm of these muscles can lead to obstruction of urination. The urinary valve or sphincter, which helps hold in urine, is also a muscle and works in conjunction with the pelvic floor muscles. Spasm of these can also lead to obstruction of urination as well as pain. Botox is injected directly into the bladder muscle through an instrument placed in the bladder called a cystoscope. This is a telescope that allows your doctor to inspect the inside of the bladder and is passed into it through the urine channel called the urethra. The procedure is usually performed on an outpatient basis, meaning that no overnight hospital stay is required. In most cases, only local anesthetic or freezing is required. However, some doctors may also give sedative medication, and some may prefer to perform the procedure with the patient under spinal or general anesthetic. Typically, the procedure takes only 10 to 30 minutes. The procedure is done in either an outpatient procedure unit or an operating room. You will be given instructions on how to get into the area. After arriving to the specific area, you will be requested to change into a hospital gown. You will be taken to the room for the procedure. You will then lie down on the procedure table. Female patients will have their legs placed up in stirrups, while male patients may be treated with their legs down flat. Freezing or anesthetic jelly is initially passed into the urinary passage, called the urethra, to numb the lining. Then a catheter, which is a tube, is passed into the bladder, and the urine is drained. Through this catheter, another local anesthetic or freezing solution is placed into the bladder to numb its lining. After waiting 15 to 20 minutes for the anesthetic to take effect, and after mixing the Botox solution to prepare it, your doctor will then pass the cystoscope into the bladder and inspect it. A small flexible needle is then introduced through the cystoscope to perform the injections. Anywhere from 10 to 30 injections are usually made into the bladder, and at each site a small amount, typically 1 milliliter, of Botox solution is injected. The bladder is then drained and you will be discharged home after ensuring that you can urinate if you are able to do so prior to the procedure. If you are unable to urinate, you may be taught to self-catheterize before going home. Depending on the preference of your doctor, you may or may not receive a prescription for an antibiotic afterward. You should not experience significant pain during or after the Botox treatment, although it may sting or burn when urinating the first few times. You may also see some blood in the urine initially after the treatments. It may take 5 to 7 days for the effect of Botox to be known. Initially, you may not notice any change in your urinary symptoms, but over several days to a week or so, you should begin to experience relief of sudden urges to urinate and a lessening of the frequency and severity of leakage episodes. You will be able to hold your bladder for longer periods of time between urinations and will wake up less frequently to empty your bladder. If you are taking medications by mouth to relax the bladder, you may be able to wean yourself off of these once the Botox treatment begins to take effect, and your doctor will advise you about this. Associated with this relief in symptoms, you may also notice that it becomes more difficult to empty your bladder when urinating. This is because Botox works by relaxing the muscle of the bladder, and therefore not only relaxes it to relieve symptoms, but also weakens its ability to contract and empty. For some people, this change does not completely prevent them from emptying, but for others it can. In these cases, the bladder must be mechanically emptied by introducing a small catheter or tube into the bladder periodically. This is called self-catheterization, and is the most effective and safe way to treat a bladder that cannot empty itself. While the concept of it may be unappealing at first, it is really a simple process to learn, and it is painless. A separate module discussing self-catheterization is available for review if needed. Eventually, the effect of the Botox will begin to wear off, and you may notice a gradual return of your symptoms of frequent and urgent urination, as well as leakage episodes. You'll begin to empty your bladder with greater ease again. As every patient is different, it is impossible to predict how long after your treatment this will happen. The treatment effect will commonly last for 3 to 6 months, and sometimes up to 8 or 9 months or more. As mentioned, you may see some blood in the urine initially after the treatments. Significant bleeding after the procedure is rare. Bladder infections do occur in some patients. These are rarely the result of the procedure itself, which is done under sterile conditions. More commonly, they are caused by incomplete bladder emptying as the Botox takes effect, and occur several days after the procedure. Notify your doctor if you are concerned about a possible bladder infection. Self-catheterization to help empty the bladder may prevent infections from recurring. Overall, up to 1 in 5 patients may require temporary self-catheterization. As noted, a separate module is available that discusses self-catheterization in detail. Other very rare potential adverse events, which occur in less than 0.1% of cases and have never been described after bladder injections, include an allergic reaction, including anaphylaxis, erythema multiforme, which is a severe skin rash, and generalized weakness. Notably, death has never been reported in relation to bladder injections of Botox. You should not receive Botox treatments if you have any of the following: myasthenia gravis, or Eaton-Lambert syndrome, an active bladder infection, pregnancy, as the effects on the fetus are unknown, and a known allergy to Botox. The clinical experience with Botox for urinary incontinence is early still, and data are pouring in from a number of research trials being done around the world. It is safe to say, however, that Botox has been proven to improve the functional size of the bladder and to reduce spasticity of the bladder muscle. Overall, there is a 60 to 90% chance of achieving significant improvement in urinary symptoms and leakage following Botox injections. All of this leads to a greater quality of life for the vast majority of patients treated. In summary, Botox, which is botulinum toxin A, blocks the release of a chemical signal from nerve cells to muscle cells, causing relaxation of the muscle. It has been used in a variety of bladder and pelvic conditions, including neurological bladder problems and overactive bladder and urge incontinence. Its use in these conditions is considered off-label at present. Botox is injected directly into the bladder muscle. This is a simple outpatient procedure usually done under local anesthesia or freezing. It is a safe procedure, although there is a small chance of needing to catheterize oneself to empty the bladder afterwards. Botox injection into the bladder is highly effective in the right patients to reduce bladder symptoms and leakage and improve quality of life. These resources may help you find further information or support about your condition and about Botox. These references were used to assist in preparing this presentation and are available at your local medical library. These references were also used. We sincerely hope that this module has furthered your understanding of Botox treatments for bladder conditions. We wish you the best for the future, and thank you again for viewing this educational program.